who's taken about 5 liters of water over 2 hours of running, or any form of symptomatic hyponatremia. More so in patients with SIDH because you don't want to give a lot of volume. You just want to give more sodium at the expense of less volume. So what it does, it increases your sodium by 1 mils per kg will increase your sodium by about 1 millimole. There are different ways of giving it. You can give it as an infusion or you can give it as a bolus. You don't need a central line. So how do we deal with the specter of osmotic demyelination syndrome? Know the patients who are at risk. And our patient actually had 3 risk factors. She was hypokalemic, she was elderly, had taken thiazide, and sodium was actually quite low. You can also argue that she was probably malnourished. So for the high-risk patients, try and get that sodium up by only 6 millimoles in 24 hours. And be prepared to use a prophylactic desmopressin. If you think the patient is low risk, you can allow a larger margin of increment. And if you feel you've overcorrected, the patient is well, no symptoms, try and bring it down. The traditional way of doing this is actually to give 5% dextrose, but there's no harm in giving desmopressin as well. So we move on to talk a little bit, I think we still got a bit of time, we can talk a little bit about hyponatremia. So this is another case. You are asked to see an 88-year-old bedbound female on NG feeding with history of hypertension. She's confused, you find that she's dehydrated, she's hypotensive, and the sodium is 160. The K is normal, and the urea-creatinine ratio also is a bit high. High serum osmolality, the urine sodium is 15, urine K 80, and urine osmolality is very high. Her urine bag, last drained 24 hours ago, has about 100 milliliters of urine, and city brain is unremarkable. So what is the least likely cause of her problem? So it's unlikely going to be diabetes insipidus here. Why? A high urine osmolality and a urine osmolality greater than plasma osmolality exclude diabetes insipidus. What it suggests is actually there's a lot of ADH at work there. In diabetes insipidus, ADH is not or inadequately acting. So your urine osmolality would actually be lower than your plasma osmolality. So essentially, hyponatremia is the counter to hyponatremia. The sodium is more than 150. So it's more of a water deficit than a sodium excess. You will not find it in normal people walking around who are deep sick, who are able to drink, because thirst is the best defense against hyponatremia. Okay? The moment your plasma osmolality goes more than 285, ADH will kick in so that then you can conserve more water. And that will also stimulate the thirst receptors. Absence of or inability to appreciate thirst, aphasic patients, stroke patients, or inability to say, look, I'm thirsty on itself, may lead to hypernatremia. And this picture here is very interesting because what they did was they used rats actually in whom you can actually stimulate the thirst and the osmoreceptors by using certain laser stimulators. So you can actually induce a form of neurogenic DI depending on how you stimulate it. And you will find that actually those rats in whom you are induced hypernatremia actually do run for the water if their thirst receptor is actually intact. So hypernatremia, more problem of loss of water. So how this happens, you can lose water from the gut, from the urine, or from the skin, or you may have inadequate ADH. Or in some rare cases, in pregnant women, they may produce this hormone called vasopressinase from the placenta, which will break down ADH. This would be called a hypovolemic or euvolemic hypernatremia. Alternatively, you can have excess salt intake, either hydrologically or deliberately. Sodium bicarb is used as an alkalizing agent in a number of instances, 3% saline as an irrigant, citrate dialysis in the ICU, senior drowning, and there are patients also who've come in because they've taken a lot of salt to chase away the spirits as well. This will be called a hypervolemic hypernatremia. You are running out of time, so a good history is important. If the urine is very dilute, okay, ask about drugs, look for causes of hypokalemia, hypercalcemia. And if there's a brain injury, you want to think about neurogenic DI as well. Is there a role for water deprivation? I think if you are the resident on the service, you're asked to this, I think it's just your bad day, because this is something that very barbaric. But I'll tell you, there's another option. You don't need to wait for the sodium to normalize. If the sodium is high, just give the patient desmopressin and check the urine osmolality before and after. So if you give desmopressin, you find that the post-desmopressin urine osmolality has gone up, so you're probably dealing with a central DI. Okay. Be caution, just like in hyponatremia. Hypernatremia is that brain adaptation, but it's the opposite. You actually get a cerebral desiccation. And if you correct it after the brain has adapted, you can actually get cerebral, and you overshoot, you can actually get cerebral edema. So the principles of management, I think yeah. So I think I will probably skip the management part, but important is you need to work out the water deficit, and also to look at insensible salt water loss as well, so that you can come up with the actual volume for you to replace. And this volume can actually be replaced mainly orally via in-situ free water with some half saline or even 5% dextrose. So in summary, dysnatremia is a very challenging issue. You need to understand the physiology. You need to understand how EDH works. It's not so much of a sodium problem, but a water problem. I thank you for your attention.
Thank you, Dr. Renaud. So we'll move on to the third talk of the symposium. So each and every patient we encounter with critical illness have got acid-base derangement. So I will call upon Dr. Rashan Hanifa to talk on acid-base imbalance. Over to you.
Right, coming on automatically. Excellent. Okay, thank you very much. Thank you very much, Chairperson. Thank you to Professor Rajapaksa and the Council for inviting me to give this talk. A pleasure. Might be slightly alarmed to know that the person who was meant to give this talk was the person who supervised my PhD. Never a good start, is it? So I am the stand-in, but a more official stand-in. So respected teachers, ladies and gentlemen, been thinking about what I might say as an intensive care doctor looking after patients who have acid-base derangement, as the chairperson alluded to, on a regular basis. I'm sure you all have a system of interpreting and understanding acid-base balance, and I think my role would be not to give you another system or try to give you another approach to looking at that. So I kind of thought maybe I'll start with a couple of messages which resonate in my mind when I look after unwell patients, and maybe focus on a couple of things which are nuanced in terms of understanding acidemia and how that might help with clinical management. So the first thing I'd like to say is a little plea. So as an intensivist or intensive care doctor, quite often you get a bit of number voyeurism. People pick up the phone and they want to tell you that they've got this patient with this number. It's usually either a pH or, as the from previously alluded, some sodium. They want you to be impressed by a number that there is a pH of 7.1 or we've got this patient. It's much more important to understand why and what the patient is than the individual number you're being told. And that leads a lot to misunderstanding and over-treatment. And I think you saw some examples of how the sodium, which was probably a problem and was symptomatic by its derangement, was then worsened by the treatment provided. And you see a lot of that in terms of acid-base balance. So that's kind of one plea. And second, directly leading from that, is to try and think, when you see an acid-base derangement, how is this affecting the patient? Because, okay, the number is abnormal, we recognize that, but how is that affecting the patient? The reason I say that also is people commonly think acid-base balance is very tightly regulated by the body. I would like to suggest that's a little bit of a myth. Because if you have a pH of 7.4, the way the logarithmic scale is set up, that gives you a hydrogen ion concentration of about 40 nanomoles per liter. When the pH is 7.2, I don't know whether it will surprise you if I tell you the hydrogen ion concentration is now 64 nanomoles per liter. So in fact, the hydrogen ion concentration has changed by more than 50%. And this is not an unusual patient in the hospital. I suggest if you took blood gases from your patient you see on a day-to-day basis, this is not unusual. It's certainly not unusual in the patient population I deal with. So perhaps the pH or the hydrogen ion concentration is not that tightly regulated. And that directly leads to my first point about try to understand how this alteration in hydrogen ion concentration is actually impacting the patient. So for example, a person with COPD who has a pH of 7 is very different from a person with diabetic ketoacidosis who has a pH of 7. And I think that's really important, and perhaps you might see that theme as we try and discuss a couple of examples. So the theme I decided to try and touch on during this little talk is maybe an anion gap. And I thought maybe that's a good thing to highlight and maybe provide a little approach to how you might interpret changes in the anion gap and how you might anticipate and understand compensation in terms of an anion gap, and how that as clinicians that might give you a little more information to treat this patient. So I thought maybe I'll work through a couple of examples, maybe a third one. Just trying to see that this comes up. So in this patient, if I told you these are kind of the numbers, I'll let you have a little look at those numbers. So this patient is obviously quite unwell, not dissimilar to the patient who gets referred when you work in an intensive care unit, pretty unwell. And a common question, is there an anion gap? You might ask, how is that important? Maybe I'll try and highlight that in a moment. So what is an anion gap? The anion gap is talking about the difference between measured cations and measured anions. Just looking to see, the screen doesn't come up here. Oh, sorry, it's me being blind. Thank you. So it does show the difference between the measured cations and the measured anions, and there is a component of measured anion, unmeasured anions, which contribute to this anion gap. Predominantly, it is the proteins and the sulfate. Now, another important thing when we understand that is that there is a compensation required to interpret the anion gap if the proteins are low. Because a lot of the anion gap is contributed by these proteins, if the albumin is low, for every 10 grams of albumin below the normal level, you do need to make an allowance for the anion gap of 2.5 milliequivalents. Now, you might think that's not so common in patients, but in the critically unwell patients, you will not be surprised to think that's quite common. You see this albumin derangement quite often, and as we know, that doesn't always correlate with survival. So if the anion gap is high and the pH is low, then this patient does have a metabolic acidemia. And I thought maybe I'll focus on that and try and illustrate a couple of examples which show how that varies in these patients and how the anion gap might inform your interpretation. So if the anion gap is high, there is a metabolic acidemia with a low pH, and the bicarbonate is not low. Because if you go back to this equation, if the bicarbonate is not low and the anion gap is high with the metabolic acidemia, it does mean there is another disorder present. And going to the strong ion difference, which I'm not going to try and describe, it includes derangements in chloride are likely. And touching on the previous speaker's comments, it might be because we have resuscitated someone with lots of chloride. which is now causing a hyperchloremic acidemia, again, which you will be able to detect by looking at the anion gap in this way. So if that is the case, may I then propose a slight advance? You might want to look at the anion gap in relation to the bicarbonate. So how has the bicarbonate changed in relation to the change in the anion gap? So that's a delta anion gap divided by delta bicarbonate. So how this helps us is, if this change, if the bicarbonate change doesn't directly tally the anion gap change, it alerts us that there is something else going on. And maybe I will use a couple of examples to highlight that. And you can see if the ratio is 1, you can be fairly confident that this is a high anion gap acidosis, and what you're seeing is probably representative. The bicarb is representative of the problem, and you will be able to interpret that relatively easily and be confident that there is no second disorder, no second metabolic disorder, to be precise. However, if the ratio is not 1:1, then perhaps there is another metabolic disorder going on in this metabolic acidemia. Why do I say that? Perhaps you'll see. Maybe this is a medical school acronym, mud piles, again, just an acronym to try and illustrate the causes of a high anion gap acidemia, quite often asked in examinations, and a kind of a good acronym to work your way through once you spot that somebody has a metabolic acidemia with a high anion gap, and that includes things like cyanide. So going back to our example of the gentleman we were discussing, so this patient does have an anion gap which increased. It is 18. If we consider 12 as the normal for the upper normal limit for anion gap for this calculation and example, we can say there is a derangement, and if we do the delta anion gap divided by the delta bicarbonate, if we take the lower level of the bicarbonate as 24, then you can see that the ratio is 1:1. So I'm not going to touch on the osmolar gap. I don't want to confuse and make this more complicated, so I'll pass that for the moment. But if I just work through this, I'm sure you all appreciate there is an acidemia, and it's now pretty obvious there is a metabolic acidemia. So is there any compensation? Again, I'm sure you all have your own way of working that particular bit out. But I think it's sufficient to say if the direction of the CO2 is in the opposite direction to benefit the acidemia, then there is compensation. So in this case, I think you can see there is respiratory compensation. And I want to touch, maybe you can also try and predict the extent of compensation. Now, this kind of number helps me interpret a blood gas, because it helps me understand that for every CO2 coming down by 1.2, so if there's a metabolic acidosis and there is a reduction of bicarbonate by a millimole, that will be followed by a CO2 reduction of 1.2 millimeters mercury. That's the kind of compensation you are expecting. So if you're looking at a blood gas, and in this patient we saw the bicarbonate had changed by 6 millimoles, then you're expecting a change in CO2 of about 8 millimoles. I don't know whether that makes sense. So if you now look at that patient, it does suggest there is a compensation. It is a respiratory compensation. And if we look at the ratio, we can be fairly confident that this is just an anion gap acidemia. So if I'm just going to go through, skip the AA gradient, not to make this any further complicated. But if we now think what the diagnosis may be, I hope it will not come as a surprise to you that this person has a high anion gap metabolic acidosis with some respiratory compensation, and there is a high lactate, and that's causing the acid-base disturbance. If I move on to another example to maybe show a slightly different nuance to what I have now illustrated. So this patient is an asthmatic patient who's presented to emergency, has been using an inhaler quite often. The asthma has been getting worse and is now in hospital. So again, some blood gas results for you to consider with an oxygen-inspired oxygen concentration. So this patient does have an AA gradient, an alveolar arteriolar gradient. Like I said, I'm not going to go into that, but perhaps you'll concentrate on the acid-base disturbance and think about those numbers we discussed and how you might go about interpreting that in your own mind. So as I work through that, again, is there an anion gap in this patient? Yes, there is. And the anion gap is 17. So going back to our concept of can we try and see whether the bicarbonate is following this change in anion gap, you can see the change in anion gap is 5, but the bicarbonate change is only 3. And therefore, we should be wary that there is perhaps a metabolic process in addition to what we are seeing. I pass through the osmolar gap again. So just trying to work through this. Is there an acidemia? Yes, there is. Is the primary derangement respiratory or metabolic? Again, I hope it won't come as a surprise to you, given the extent of the pH derangement and given the extent of the CO2 being high. This is obviously a respiratory acidemia at its source, and given the history correlating to what we have heard of the patient. Again, I hope it will also be not a surprise to you that this patient is very unwell, an asthmatic patient with this kind of CO2 causing this kind of acidemia is very unwell, and you would say that this is near life-threatening asthma, if not already requiring very, very urgent intervention. So is there compensation? So going back to our previous calculations, if we kind of think of the numbers, is there compensation? Going back to our equation of expected compensation, if there is an acute respiratory acidosis, we expect the bicarb to go up by 1 millimole for every 10 millimeters mercury. This is the other way around to what we discussed earlier. So we want the bicarb to have gone up, but in this patient, you can see the bicarbonate is actually lower than normal. So does that mean there is no compensation? No, it doesn't mean that. It means there is a compensation, because if you go back to our conversation about the anion gap, it suggests there is a metabolic acidemia. And if we went back and looked at the ratio, we expected the bicarbonate to have reduced by at least 5 in relation to the anion gap acidemia. However, it hasn't. And in fact, the bicarbonate is only 3 lower than what you would expect. So in this patient, what you're having is an additional metabolic process. So again, I hope it will not come as a surprise to you in an asthmatic patient who's breathing very fast and very hard. There is a strong element of hypolemia, and you see these in these patients. So the metabolic, the acidemia you're seeing may be mixed and is quite often mixed. How is that important? When you try and intervene with this patient, whether that is an intubation or whether that is trying to rescue, some people might try something like non-invasive ventilation. I suspect the patient we are discussing is beyond that stage. But if you were to try and intervene, you have to understand the metabolic derangement you are seeing may be more than the respiratory element. And I think this is a very good example to interrogate the numbers you're seeing a bit further. So if the CO2 being high is not reflected in the bicarbonate change in relation to the anion gap, it alerts us to think that there is perhaps a metabolic element going on despite the compensatory efforts. I realize that's a little tricky to convey in a talk like this. I understand it's a little tricky, but I hope that alerts you in your mind when you try to interpret derangement in acid-base balance to consider the anion gap and to consider whether the bicarbonate has followed the change in the anion gap. And if it hasn't followed that change, perhaps be alert there might be another process going on, whether that causes an increased anion gap acidemia or a non-increased anion gap acidemia. I hope that conveys a little bit. I do understand it's a little tricky to convey this kind of thing in a talk like this, so apologies for trying. So just going back, is there another disorder present? Yes, there is, and the other disorder is metabolic. And quite often, what is this disorder? In this patient, I just rushed through that a little bit. As I said, you get increased work of breathing, you get anaerobic metabolism, and you get a significant element of hypovolemia. And when you intubate these patients or you try to treat them, they are far more unstable than they appear. And that's very important in the risk stratification and management of these patients. And quite often people who haven't recognized this metabolic derangement are the people who walk into that unanticipated challenge. So perhaps that's helpful in understanding that. So this patient does have an acute respiratory acidosis. There is an element of compensation because the bicarbonate is not as low as it should be, and there is a metabolic acidemia going on with that. So I'll move on with that. Time's coming up. So just to summarize, so I wanted to try and highlight a couple of things. Firstly, to say acid-base disturbance must be viewed in context of the patient. What do I mean by that? Is to try and understand how is this acidemia, which is the predominant problem people worry about in hospital, when they see an acid-base disturbance, how is that affecting this patient? What is the danger we are anticipating, and what is the evidence that danger is coming to pass? And how are we going to manage that? It then forces you to think, what is causing that acidemia? You then have the decision tree, is that high anion gap acidemia, or is it a normal anion gap acidemia? If it is a high anion gap acidemia, is the bicarbonate following the derangement you are seeing in that anion gap change? If it is not following that, then perhaps there is another metabolic process. And that is probably the take-home message for this morning from me. Thank you very much for your attention.
Thank you, Rashan, for your excellent talk. Now we can take a few questions, and it's open for questions. Yes, we have a question.
I think I'm coming through. Yeah, I'm Professor Saroj Jayasinghe, Professor of Medicine, University of Colombo. It's a provocative but a serious question I want to ask the panel. We've had an excellent plenary and also a lecture by Professor Bell, who emphasized the importance of clinical skills. Now, on the other hand, you have the specialist coming up with these various algorithms. My question is very simple, especially to Rashan. Why can't this be given to us by a simple program which is inbuilt to the blood gas machine? So that, I mean, this is a simple algorithm. You do the analysis and you get a readout saying the differential diagnosis, and then the clinician just has to look at that and say, this supports us. Because sometimes the blood gas machines even do not give us the normal range for bicarb. I just can't understand why it doesn't. Rashan, put you in a spot.
Thank you, Professor Saroj. I was going to say, when I started, I should have said no questions from Professor Saroj. but since I didn't say that, I can't say that now, so let me try. So I completely agree. I couldn't agree more. What I would say is I think it's coming. And in fact, it's come in many places already. So if you look at your 12-lead ECG, how many of you don't have it being interpreted already by the computer? So in Sri Lanka, I know it's that long lead ECG. Is it still that strip? Is it still that strip, or is it a 12 lead in one sheet? Okay, so basically in pretty much any high-income country, when the computer does the 12 lead ECG, it now interprets it. There are Twitter and Facebook tags about wrong interpretation of the computer. But it's a start because it gives, basically now the nurses, when they ring you, because it tells you left axis deviation, left ventricular hypertrophy, atrial fibrillation, it's already telling stuff. It can be wrong. It can get it wrong, but it's coming. In terms of the blood gas machines, the EHRs already have these flags. So maybe I propose a slightly opposing question or comment. A lot of people, especially in the United States, have alert fatigue. They are irritated by the number of messages these computer systems give them, unasked for and unsolicited, disrupting what they think is their clinical mind. So I think there's a balance between that, but I completely agree that the darkness we seem to operate is unnecessary, because surely what I have proposed this morning is a series of simple rules which can be interpreted and provided at the point of care by a computer. Whether the clinician agrees with that or disagrees with that, in my opinion, is a further advance and only a good thing. I don't see that as a problem. Some people, some people see the devil in all of these things. They'll say, what if the computer says this person was hyperchloremic acidemia and they weren't? And you kind of think, at the moment, the computer is already telling you this person may be having atrial fibrillation, and maybe they are not. It is up to the clinician now to take that advice, because that may be a junior colleague telling you, or a computer, and to make an informed decision by looking at the patient. I don't know whether that helps. See, I seem to have been not talking into a working mic. Okay.
There's another question.
Thank you very much for your talks. I suppose there's a thread for me around understanding the pathophysiology is necessary to make the right diagnosis, especially in difficult cases. And I suppose metabolic emergencies, not vitamin D, but metabolic emergencies, are often poorly managed. I think that would be certainly our experience in the UK. So my two points. One is in relation to the sodium imbalance ones. Part of the reason you move them to HDU is to monitor them, and there's a concern for me that we do not monitor them frequently enough. Just like your comments on that, you suggested 4 or 6 hours. I wonder if that's frequently enough when people don't fully understand what they're doing. And the second thing is going back to your point, if we used an acid-base nomogram, that would probably cover 70 or 80% of our patients, and it would teach them pathophysiology. So should we not just be encouraging people to use acid-base nomograms?
Thank you for your question. I think it's very interesting. But I'll also try and answer your question by referring also to the earlier comment and questions put across recording based on whether you can introduce AI, artificial intelligence, in making diagnosis when it comes to acid and electrolyte imbalances. My straight answer is actually no, because context matters, and I think cognition also matters. Every case is different. And I think if you don't take what I call a step back, take the eagle eye view and analyze all the potential, introduce some form of, I think you still need somebody who's cognitively attuned to the underlying pathophysiology. I think that's key, rather than just solely relying on algorithm.
Is it okay if I try? Do we have a minute or stop? Stop? Okay. So maybe I try. So I completely agree with the sodium point. So quite often, so I have two perceptions I'm happy to be disagreed with. The first is I suspect we have far less control of things like sodium control than we like to think as clinicians. That's kind of one perception I have as somebody who manages very deranged sodium numbers with a hypo or hypernatremia. I think we have far more control than we actually have. Happy to be challenged on that. Secondly, quite often the reason you admit someone to HDU is to stop people making things worse. Just stop. Because what happens is people intervene thinking they can control these numbers in a very fine way. And the level of monitoring required for that and the level of diligence and manpower and intensity and the clinician buy-in you need to achieve that is quite a lot. And in my experience, looking at these patients, even in the intensive care unit, I have a little game in my mind. What I do is when they admit someone with a sodium or a potassium imbalance, I kind of ask them, what are your targets for the next 24 hours? And then I just watch to see whether we achieve them or whether it's anywhere close to what we actually intend. And quite often it isn't. So that's kind of a plea maybe to be a little less ambitious in what we set out to achieve and be a little more aware of our limitations in achieving those targets. That's kind of one perception. And secondly, just to answer the question about the nomogram, I definitely think for the non-expert, as they go on this journey to becoming the expert, because it does require the expert to guide those tricky, complicated patients, it does allow the non-expert a voice to raise, and it gives them a framework to work from, to engage with the expert and ask a question. Because otherwise I find the gap between those two groups of people is far too big. Because otherwise the experts are having the expert conversation and the non-experts are not understanding what's going on.
We can allow one more question, quick question.
Since there's no other question, I thought I'll reiterate my position. I think I'm thinking of artificial intelligence actually subservient to human intelligence in this instance, so that the clinician really sees the whole big picture, and he wants from the blood gas machine just a guide, because he's dealing with the blood gas, he's dealing with the blood glucose, he's dealing with the anemia, and he's dealing with the renal failure, and this is just one small area. So in that, the internist is in control, and he wants a bit of help from the different machines. So it's human intelligence and the artificial intelligence playing a subservient role, because I'm a hardcore clinician. Thank you.
Thank you, sir. And to wind up the sessions, I will call upon Professor Senaka Rajapaksha to give away token of appreciations to all the speakers. Professor Kursi Islam. Dr. Claude Renaud. Dr. Rashan Hanifa.
Most important.
Thank you, sir. So now we are breaking up for tea, and there's a housekeeping announcement. There will be fire drill alarm at 11:30. Don't be panic. Okay.
And also,
Thank you.
And also, just to mention that the college, the society tie is available at the reception if anyone wishes to buy one.
මෙහාට මේක තමයි. කොහොමද අපි ලෙලෙඩි දෙන්නේ? only 1 minute. That's okay. lunch එකෙන් ගන්න පුළුවන්. මේක තමයි. දැන් ටිකක් කවුඩ් එක බෙට පටන් ගන්න. මේ කන්සෙප්ට් එක ගන්න ඒ වගේ ඉනෝවේෂන් එකක් ඒක කරන්නේ. මම ගානේ වෙනවා. එහෙනම් කොහොමද ඉන්න ඔයාගේ තෝන ඇවිත් ඉන්නේ කොහොමද ඉන්න. සත්‍ය ඉන්ඩස්ට්‍රි බලන්න කොහොමද probably form we can probably find two missing. That's it. Got my point half of it audience. We'll see. බලමු ඉතින් මම කියන්නේ මට පොඩ්ඩක් වඩා වෙකින් ගියා. We'll see. මේ අවුද බෑ. it 20 වල මම ගන්නවා. මම ගන්න I'll take it. ඒක 2 වල 2. අපි දාපු circle cycle දෙකක් ගිහින් අපි යමු not center cover controversial because too young to become president. Too young. විනාඩියකින් පටන් ගමුද? ඔව්. ඔව්. දැන් මෙතන තියෙන මම මේ start කරන්න.
Good morning, ladies and gentlemen. Welcome to the second plenary of the SIMCON 2018. The plenary speaker actually needs no introduction, but for those of you who were not there in the morning, the next speaker we have is Senior Professor Janaka De Silva. He is the Senior Professor of Medicine at the Faculty of Medicine, University of Kelaniya, and the Director of the Postgraduate Institute of Medicine, University of Colombo. Professor De Silva will be delivering his plenary lecture on medical management of advanced cirrhosis. Over to you, sir.
Thank you and good morning. So let me start by saying that advanced cirrhosis is such a common problem that a significant proportion of these patients
are managed by general physicians. And it is therefore important that the general physician should understand some of the principles that underlie its management. So the clinical indicators of advanced cirrhosis are all associated with poor outcome. Intractable ascites, bacterial peritonitis, hepatorenal and hepatopulmonary syndrome, encephalopathy, recurrent variceal bleeds, and hepatocellular carcinoma. And all of these indicators correlate well with two common models that we use to predict survival, the Child-Pugh score and the MELD score, or the model for end-stage liver disease. So we are dealing with a problem that has a very poor prognosis, but there is a definitive, potentially curable curative treatment, and that is liver transplantation. And all physicians looking after patients with advanced cirrhosis should know when to refer patients for transplant assessment. And the rule should be that you should refer early when decompensation develops in a life-threatening situation. Although there is no clear cutoff for age for transplant, most transplant centers will willingly accept patients less than 70 years of age to be considered for transplant. There are two main indications for transplant. One is decompensation, child class B or C, or a MELD score of equal to or more than 15. And these scores can be a little lower for some specific complications of advanced cirrhosis, though they are rare, like intractable pruritus, recurrent cholangitis, or hepatopulmonary syndrome. The second important indication for liver transplant is hepatocellular carcinoma, and here there are clearly laid criteria as to when you should transplant a patient, and they are called the Milan criteria, and they say if you have one lesion less than 5 centimeters in diameter or no more than 3 lesions which are less than 3 centimeters each, when there is no macrovascular invasion or extrahepatic disease, these people may be suitable for transplantation. In a rather simple but impressive and, for me, a very practical approach, a group led by D'Amico in 2006 actually tried to stage cirrhosis using 3 very easy variables: varices, variceal bleeding, and ascites. And in this table, you can see in the last column, you can see if a cirrhotic patient has no varices, no bleeding, and no ascites, they have a very low 1-year mortality. Whereas if they have all 3, there's nearly a 60% mortality. So they suggested that anyone at stage 3 or above should be sent for transplant assessment. So basically what all these models are saying is that when a patient with compensated cirrhosis becomes decompensated, get a transplant assessment. But there are contraindications, as you know: severe cardiac or pulmonary disease, alcohol addiction without any motivation for abstinence, hepatocellular carcinoma with extrahepatic metastases, extrahepatic malignancies, sepsis, chronic infections, and so on. And lists are available at any website which will tell you absolute and relative contraindications. So what this all means is that many patients are not candidates for liver transplant, either for clinical reasons or for social and financial reasons. And even the number who qualify for transplants are far in excess of the available donor organs. The situation is so bad that nearly 15% of patients on a transplant waiting list die each year, and many more are delisted because they become too ill for liver transplant. Most of these cases, therefore, have to be managed medically. And although what we practically then do is a kind of palliative treatment for these patients with advanced cirrhosis, because we are not offering them a cure, advanced cirrhosis, surprisingly, has only recently been the focus of palliative care research. And best practices in palliative care for cirrhosis are still not defined like they are for malignancy or chronic pulmonary disease and so on. And so in the next few minutes, what I would like to just go through with you is some evidence-based do's and don'ts for some of the commonly mismanaged complications of advanced liver cirrhosis. Let us start with resistant ascites and bacterial peritonitis. All patients with ascites should have a diagnostic paracentesis, regardless of coagulopathy, to look for infection. Spontaneous bacterial peritonitis leads to a very poor outcome in cirrhosis. They should be treated aggressively with intravenous antibiotics, usually third-generation cephalosporins, and all of them should be started on secondary prophylaxis on discharge, usually with quinolones. And these three graphs on your left, the first one shows that the probability of remaining free of infection and survival are both better in patients taking an antibiotic, up here, than those who were on placebo. And in the last graph, you can see that both ciprofloxacin and norfloxacin seem to be equal in their efficacy of preventing recurrent attacks. In the management of ascites itself, what a lot of people forget is the importance of sodium restriction to 2 grams a day to be combined with diuretics. However, most of these patients who have resistant or intractable ascites need serial large volume paracentesis with or without IV albumin, and that is the mainstay of therapy for most of these patients. Because of recurrent hospitalization, people have tried using indwelling peritoneal catheters, but these are not currently recommended universally because they have a higher risk of infection and bleeding and so on. It's also important to know that when you are treating intractable ascites, these patients have severe portal hypertension, and therefore low systemic blood pressure. So drugs that lower blood pressure further, like beta blockers, especially carvedilol, and ACE inhibitors, should be discontinued, even if it is temporarily so. In patients who are selected, we can consider TIPS. It's available in our country, but it's very expensive because most of the TIPS is done in the private sector. Another lesser understood complication is this condition called hepatic hydrothorax. This is the development of pleural effusions, mainly on the right side, in patients who have gross ascites. And again, the treatment is very similar to ascites. Diagnostic thoracentesis to exclude infection, and the management is with diuretics and thoracentesis in patients who develop dyspnea. And again, like in our management of chronic ascites, chronic pleural drainage with IC tubes is not recommended due to very frequent complications like bleeding. If you put in an IC tube into one of these patients, you're in trouble because you can never remove it. It will continue to drain and drain. Pleurodesis using talc and tetracycline can sometimes be used in patients with refractory hepatic hydrothorax, but the results are a bit mixed. Hyponatremia is probably the most mismanaged problem in cirrhosis that I see in my practice. It is very common in advanced cirrhosis, and what people forget is that it is a hypervolumic hyponatremia. It's dilutional. It's not due to an excess urinary sodium loss. And this flow chart will give you the reason why in patients who have portal hypertension, there is systemic vasodilatation, decreased renal blood flow leading to activation of the renin-angiotensin system, which increases sodium retention, and also an increase in non-osmotic ADH release, which results in a solute-free water retention, which is a little in excess of the sodium retention, and therefore you have a dilutional hyponatremia. Before I go on to treatment, a word of caution. Routine correction of asymptomatic and mild hyponatremia is not recommended by any of the guidelines. Indications for correction are either the development of neurological symptoms and or a sodium of less than 125 milliequivalents per liter. These are on all the guidelines, the European, the American, and the Asia-Pacific guidelines. So you don't have to treat a cirrhotic with a sodium of 126 who is having no neurological problem. They're quite used to having that level of sodium. Remember that there is no sodium depletion here. It's just that their volume, it's the water that is causing the sodium to appear low. Fluid restriction is the mainstay of treatment, starting with about 1.5 liters restriction per day, and then increasing it to even a restriction of 1 liter a day. Sodium restriction should be continued, and I want to emphasize this point because these people have ascites. And if you give these people sodium, it will make the matter worse. And I hope you understand this now by the flowchart I showed you. Administration of 3% saline, like the previous speaker said, should be considered only in exceptional circumstances when the sodium is very low despite fluid restriction. And as he also alluded, rapid correction of sodium of more than 9 milliequivalents of liter over 24 hours may lead to pontine myelinosis and seizures. So you have to be careful when you're correcting sodium. Two of the other things that can help to correct the sodium is the correction of hypokalemia, and I must confess that today is the first time that I clearly understood why that is after listening to Dr. Reno and giving intravenous albumin to correct osmolality. What about the vaptans, the vasopressin receptor blockers that can raise sodium? Tolvaptan, satavaptan, lixivaptan, available here. They are currently not recommended for use in patients with advanced cirrhosis because of the risk of liver damage. And this is a statement from the FDA as well as the European Association for Study of Liver Disease. So you should be very careful when you're trying to use vaptans in patients with cirrhosis for hyponatremia. Let's move on to hepatic encephalopathy, a chronic problem. And I love this slide. It's not mine. I got it from a lecture from the last DDW meeting. There are several grades of encephalopathy. So covert and overt. Then there is episodic, which happens less frequently than once in 6 months. Recurrent, which is more frequent, and persistent, which never get resolved. And then there is encephalopathy precipitated by a specific factor or spontaneous. So the treatment is to correct the precipitating factors And for episodic hepatic encephalopathy, the evidence is metronidazole and lactulose. And there is now very good evidence that L-ornithine, L-aspartate intravenously helps in the acute situation. In recurrent or persistent hepatic encephalopathy, we are left with lactulose with or without rifaximin, a non-absorbable antibiotic. It has been shown to reduce recurrences by 50%. It may improve refractory hepatic encephalopathy, and it has been shown to improve cognition and coordination in minimal hepatic encephalopathy, very important because these people sometimes drive. Things like fecal microbial transplants are experimentally being tried in patients who have refractory encephalopathy, but they haven't got into routine practice yet. So one of the don'ts that I want to emphasize here is that protein restriction is not recommended in hepatic encephalopathy unless a patient is very severely protein intolerant. So 1.2 to 1.5 grams of protein per kilogram body weight should be given, and we should also look after the energy requirement. Variceal bleeding is well managed in general. Very few patients now die of an acute variceal bleeding in our country or worldwide. Acute variceal bleeding should be treated initially with terlipressin or octreotide, followed by endoscopic banding ligation. I mean, that's the gold standard. And non-selective beta blockers should be given to prevent recurrent bleeding. We all know that when they are not contraindicated. One of the beta blockers that have recently shown more promise than propranolol is carvedilol, because it also has alpha receptor antagonist properties, but with it comes some problems. So beta blockers are our friends. They have been the mainstay of treatment for portal hypertension for more than 35 years, reduces the incidence of first and recurrent variceal bleeds, carvedilol slightly better than propranolol, improves survival when portal pressure is reduced. One must remember that only 50% of patients that we start on beta blockers actually respond to them. And unless you measure portal pressure, you're not going to find out who the responders are, although recently there has been some evidence that measuring splenic stiffness, like we measure liver stiffness, may be able to give us an answer as to the responders and non-responders. But they can also be our enemies, because beta blockers can cause renal dysfunction and mortality in the presence of refractory ascites in a dose-dependent way, manifested by a decrease in mean arterial pressure. And careful dosing or discontinuation should be done in the presence of refractory ascites, as I said earlier, if there is a systolic blood pressure of less than 90, especially carvedilol, or where there is evidence of acute kidney injury. It is also to be remembered that you can restart it once the acute situation is resolved. Now, as we do better and better, as we get better and better at managing advanced cirrhosis, patients continue to live longer and longer, even with advanced cirrhosis. And one of the complications that we are seeing increasingly is hepatocellular carcinoma. It is a nasty cancer. It has the lowest survival of any cancer next to pancreatic cancer. So it's a nasty thing to get. And the way to deal with it is, therefore, to detect it early. Patients with cirrhosis have an increased risk of hepatoma, we know that. Screening is recommended with ultrasound of the liver with or without alpha-fetoprotein every 6 months, because surveillance will lead to early stage diagnosis, a higher rate of curative treatment, and improved survival. And the diagnosis of this tumor is confirmed by imaging, multiphase CT or MRI. It is only very, very rarely that we would need cytology or biopsy to diagnose these tumors. And it can be dangerous because they are very vascular. Treatment modalities are available in this country: transarterial chemoembolization, radiofrequency ablation, microwave ablation, absolute alcohol injection, and these are most effective for small lesions less than 3 centimeters in size. And for patients who have extensive disease, palliation is usually with kinase inhibitors like sorafenib. Very expensive, but we can get it from the state sector, from the cancer hospital in Maharagama. And the patient's tolerance for all these treatments depends on their liver function. So people who are child class B, and I'm talking about advanced cirrhosis here, will do better on these treatments than those who are in child class C. Before I finish, let us not forget general health maintenance. I feel that all clinicians who treat these patients should regularly screen these patients for alcohol use because most of them are depressed. You should consider vaccination, especially against hepatitis A and B, which can affect the liver and lead to acute and chronic liver disease, but also for influenza and pneumococcal vaccination because it can lead to decompensation. If you find that your cirrhotic is either obese or losing weight, refer early to a dietitian. Remember not to restrict protein because they lose their muscle mass. Sleep dysfunction is very common among cirrhotics, and if you find sleep inversion, treat aggressively for hepatic encephalopathy. If not, one of the drugs that is now coming into vogue is melatonin, because benzodiazepines should not be used in sedating these patients. Most patients have sexual dysfunction, and unless they are severely hypotensive, sildenafil can be used in these patients. A lot of our cirrhotics complain of pain. And the important thing to remember is paracetamol 2 grams a day is safe. And one must avoid NSAIDs because of the risk of GI bleeding. Remember that paracetamol at this dose is quite safe. Muscle cramps is another common problem to be treated. You can use vitamin E, baclofen, chloroquine, and so on. A lot of patients complain of pruritus, and I see lots of prescriptions for antihistamines. They're simply not effective in these patients. Moisturizing cream for dry skin, or if they don't have a dry skin, then you have to use drugs like cholestyramine, naltrexone, sertraline, or ursodeoxycholic acid. Don't waste your time using antihistamines. So, Madam Chairman, ladies and gentlemen, if I just may summarize my talk, liver transplant is the only potential curative treatment for advanced cirrhosis. And although we practice some type of palliation when we are dealing with patients with advanced cirrhosis, the best practices in palliative care for cirrhosis are still not defined. And I think that's the thing that we have to do. How do we manage end-stage liver disease? How do you manage a patient who is having a hepatoma but who has a Child-Pugh score of over 15? Current medical management includes, the principles include regular monitoring, evidence-based treatment of complications, and I emphasize the evidence-based here. Do not forget general health maintenance and to inquire proactively and treat common quality of life symptoms. Thank you.
Thank you very much for that excellent presentation. Now I'd like to invite Professor Senakasil Rajapaksa, the President of SLSIM, to hand over the certificate of appreciation. Thank you very much.
Good morning. Welcome to the second symposium of the SimCon 2018. This symposium focuses on current challenges to internists in Sri Lanka. And the three challenges that will be addressed in this symposium include chronic kidney disease of unknown origin, emerging infections, and dementia. We have three speakers who have expertise in each of these fields to update us on these topics. The first resource person, Professor Vijay Vanigasuriya, will update us on CKDU. Over to you, Kam.
At the outset, I would like to thank the organizing committee for inviting me to share some of my experience and thoughts about the chronic kidney disease. It is actually the topic itself I thought is a bit challenging because the topic given to me is to talk about the current challenges to the internists. A new form of chronic kidney disease started to rise its head during the turn of the millennium, and it was noted by the consultant physicians who was working in the Anuradhapura hospital at the time. And during the next 2 decades, it spread into the adjacent provinces, the northwestern province and the Ua province. Because the disease was not due to conventional risk factors, it was termed the chronic kidney disease of unknown etiology. Just to give you an overview of the disease has a male preponderance. The majority affected are farmers. People who are affected are usually at a younger age than the diabetic kidney disease, asymptomatic in the early stages, and the disease is slowly progressive, and the renal biopsy shows tubulointerstitial disease. And the end-stage renal disease needs dialysis and renal transplant. The CKD prevalence, various studies have reported the prevalence between 5 to 15% in the North Central province. Although we do not have good renal registry data, it's very difficult to estimate the numbers that are undergoing treatment, but approximately about 20,000 people in the region are undergoing treatment. Annually, about 2,000 new patients treated in treatment. About 4 to 5% of our health budget is spent on the treatment. And in addition, there's a huge socioeconomic burden. I'll not go through this slide, but you can see the major burden of the chronic kidney disease is in the North Central province, the Anuradhapura and the Polonnaruwa districts, and some areas in the Ampara, Badulla, Matale and Kurunegala districts are also affected. You can see the quite discrete geographical distribution of the disease. CKD is most prevalent in the North Central province. So I'll concentrate my talk onto the North Central province where my experience is in the North Central province. I must admit I have not worked as a physician in the region, but I have had frequent visits to these areas for my research studies. I have visited almost all these hospitals I'm going to talk about and met the physicians. So in the Anuradhapura district, you can see the worst affected areas are Medavachiya, Padaviya and Kabitigollav. And coming to the Polonnaruwa district, I will concentrate on Madirigiriya. So just to put you in the picture of the healthcare resources that are available in the region, we have the main teaching hospital where it has 2 nephrologists, 3 physicians, it has nephrology wards, clinics and the dialysis unit and a transplant unit. And there are 2 other major hospitals. One is Padaviya Base Hospital, manned by 1 physician, a renal clinic and a dialysis unit. Kabitigollav Hospital, 1 physician, hardly any facilities, even a renal clinic. There's no space to run a proper medical or a renal clinic in this hospital. And the Medavachi Hospital has a renal clinic and a dialysis unit. And you can see the distance to travel from Padaviya to Anuradhapura, though it is, the Google says is 2 hours, and actually the public transport would take quite a long time than this. Now coming to Polonnaruwa district, again, Teaching Hospital Polonnaruwa has the nephrology unit, the clinics, and as you are aware, 500-bed hospital is coming up in Polonnaruwa for the renal patients. Madirigiriya 1 physician, Hingurakuda 1 physician. Although the distance from Madirigiriya to Polonnaruwa is much less, the patients will have to spend almost their full day traveling, getting appointments and waiting in the queues. So their whole day is spent on 1 visit to a major teaching hospital. And the physicians who work at the district hospitals are either soon after board certification or they are acting physicians who are awaiting foreign training, and they do a tremendous job of work there. So the challenges in CKDU management also similar to any CKD management guideline that is available. And you have to maintain a sustainable, adequate screening program. You have to establish an accurate diagnosis. Just CKDU do not do screening programs, but CKDU, you need screening programs. You have to establish an accurate diagnosis. Treatment should be delivered without undue burden to the patient. You know the traveling, how difficult. To have a fair policy in allocation of dialysis is very challenging. To provide psychological, social and financial support for these patients. So therefore, right across from the renal clinic, which is really overcrowded, the hospital beds, which are, there may be no dedicated beds in the general medical units and the other 2 hospitals, and to the home situations where they are coming from very poor socioeconomic conditions. So all these places are challenges to the physician has to meet the challenges at each and every point in managing these patients. And also, most of these patients are under the care of the physicians and managed in the medical clinics and the renal clinics. So this is the new case definition of CKDU. Now, the new definition has given us 3 steps in the diagnosis at different levels of healthcare. Suspected CKDU at the field level, or maybe the district general hospital level, probable CKDU where you repeat the same criteria, the albuminuria and the reduced eGFR after about 12 weeks, and you have to exclude the other causes. And to confirm the CKDU, these patients need to be referred to a tertiary care center, and you have to get the histopathology consistent with CKDU, or if the biopsy is not permissible or not available, then you go as the probable CKDU. This is a 45-year-old man we met in Padaviya. He said, I was identified as a CKD patient at a mobile clinic. They said my urine samples were not good. So they asked me to go to the hospital for further tests. I'm really worried what will happen to my family. So you can see he goes to the hospital with a lot of fears and anxieties. So at the hospital, is urine albumin creatinine is available? Yes, Padaviya Hospital it is available, creatinine is available, but it is not the standardized method. So you can have some faults in calculating the eGFR. Ultrasound, it may or may not be available. Sometimes the machine may be available. So the physician, if he is interested, might travel to Anuradhapura and learn about this and come here to do the ultrasound. Renal biopsy not available. So the physician at the base hospital is left with He has to take the decision, should I manage this patient with a probable CKDU or should I refer him to the tertiary care center for the confirmed diagnosis? So no guidelines are given with this, which patient should be referred. So that it is the physician should, with his experience, should decide not only the patient's illness, considering his other social circumstances as well. So during this process of diagnosis, even pitfalls in diagnosis could happen. A patient, for the first time coming with serum creatinine of 6, maybe albumin positive, maybe red cells positive, you may overlook the presence of red cells, and you might think this is CKD and might ask for a date for ultrasound. So pitfalls could happen in these situations. So the clinic follow-up. There are several things the physician should concentrate. You need good surveillance, and because you have to arrange timely preparation for renal replacement therapy. You have to avoid unplanned emergency dialysis because it increases the mortality. And you have to prepare the patient for non-dialysis palliative care. As we heard in the previous lecture, most of these patients would be having conservative management. At the end, they will need palliative care. Comorbidities, not so common as in diabetic kidney disease, but they should be taken care of. Health advice and nutrition I'll describe as I go on. So the surveillance need to detect deterioration of kidney function and follow up such patients carefully. When the GFR deterioration is more than 5 ml per minute over 12 months, or the CKD stage 4, when you think the further deterioration is necessary, abrupt changes of the renal function. So all these things, the medical officer would detect these patients and refer to the physician. So he should be following these patients and giving the clinical decisions. So again, it is a question, who should be referred to the renal replacement therapy? So you can't refer everybody with stage 4 disease. Despite, we know I have seen how the dialysis facilities are improved in the area. However, the number that can be accommodated for HD and KT is still limited. However, there are no criteria to refer, which patient to refer, and the physician should decide. In addition, there are a lot of patient perceptions. They just think it's a disease that's due to our fate or karma, so they think they should carry on. I'll just read one or two. The patient think if you start a dialysis, it means you can't live more than 3 months. One of my relatives undergone dialysis and he died after 1 week of starting dialysis. So the patient, the consultant should counsel the patient, and they have to spend extra time to get over these perceptions. In addition, a lot of patients have resorted to various other types of religious, ritual, and supernatural healing practices, and spending quite a lot of sum of money on these supernatural and other practices. Kidney transplantation, again the patient perceptions are poor. Maybe they have seen what is happening at the very early stages when the nephrology facilities are not so much in the region. And as one CKD patient pointed out, even if I have money, I would never go for a kidney transplant. I would distribute the money among children. So these, they may have a better future. I must say these will change in the future because there are more people are going for the nephrology treatment and so on. So also the physicians do not have any availability or access to the data on mortality and morbidity. So they are sometimes in a dilemma with these patients. What is the mortality in these patients? If we should counsel them for this. And the physicians who are working in these areas, the counseling skills, the physicians, sometimes they feel they do not have adequate counseling skills to do this. And the follow-up, these patients have a very high symptom burden, severe anorexia, backaches, somatic symptoms, high ESR, whether they should be further investigated for myeloma, and the managing them with non-steroidals, it is contraindicated. So physicians faces problems there. Sometimes non-availability of investigations, some drugs are not available, no effective therapy, and the the trial have shown that ACI is limited the effectiveness only to lower the proteinuria. And also you have to, sometimes the patient opt out for traditional medicine and after some time they come back to the clinic. So all these are challenges that the clinician is facing. And so many social issues there. And the family is greatly affected, low income, cost of health care, neglecting other family members, marital disharmony, stigmatization. So they come to the clinic with all these burden on their heads. But does the clinician have enough time, physician has enough time to look into all these problems? Other emotional factors, associated depression, financial issues, so many other things. So as a result, I think the physician does not have enough time to look into these, and you only focus on the disease, which I suppose in the future it should change. And as a result, the NGOs also cover, there are so many NGOs which cover some social aspects. And coming to give the health advice, and the physicians are not aware the researchers are not aware what is underlying cause. So how can they tell the patient what is underlying cause? And sometimes the safety of food items, the drinking water, is it safe? Sometimes it is in doubt of the physician. So they have to be aware of the current research developments, and also sometimes they have to act against this adverse media publicity. You are all aware about the arsenic issue. What was the media publicity? The physicians working in those areas told me, we know that it is not arsenic. We have not seen arsenic among these people, but these are the issues we have to talk to the patients, and the glyphosate issue more currently. So the nutrition and anemia, most patients are underweight, and most of them are on very strict diet. They think they should eat few vegetables and not eat meat and fish, because they have very difficult for the physicians to change these attitudes. They also have food taboos in these areas. In addition to that, even if they agree to it, they can't get a good balanced diet due to their financial constraint. When we were visiting the houses, we have seen their food plate. It is, hardly adequate. And the management of anemia is challenging, because some areas, they have like thalassemia, like in Kabithigold level, and the treatment-wise, even the blood pictures are not available in these small hospitals. And erythropoietin therapy also may not be available to each and every patient. Coming to hemodialysis, the physician will have to either establish or improve existing facilities in the small district hospitals and base hospitals. And Padavi, I know the physician who took this task of establishing the hemodialysis unit. And the physician will have to manage the complications of dialysis. He needs to follow up the HD patients, because it's difficult for them to go to the main teaching hospital. So it's additional work to run a separate clinic. And also the urgent dialysis, they tell me, very challenging. The nurses does not want to do urgent dialysis because the mortality rates are very high. But they always appreciate the nephrologists. They are very supportive, accept very ill patients at any time of the day. There's no responsibility of follow-up of the transplant patients, but the patients will get admitted with complications such as sepsis, and they would always need transfer to a teaching hospital. However, to manage the sepsis guidelines, notes to give the antibiotics within first hour, they are not having appropriate antibiotics, and sometimes unless the physician is interested, get down the culture bottles and keep doing a culture and giving antibiotics is almost impossible in some of the district and the base hospitals. The conservative management is an accepted form of end-stage renal disease, and all the principles I have told you would apply here. This may be large number of patients are on conservative management due to medical reasons, patient's choice, financial constraints, and majority of these patients are managed by the physicians. And there's no comprehensive management plan on advanced care planning, plans of end-of-life care, psychological care, and the spiritual aspects. So the high proportion of CKDU patients at the end will need end-of-life care, and most physicians feel the patients are not prepared for end-of-life issues. And this is one physician told me, I was working as acting physician in Padaviya before my foreign training. If I had the current knowledge on end-of-life care, which I gained during my foreign training, I would have done a lot for the CKD patients in their terminal stages. So that is one aspect. Currently, the PGIM is concentrating on to improve the trainees' skills on the palliative care. Research, the physicians are in the epicenter of CKD epidemic. However, and also we have a dearth in the data on disease progression and the patient management. However, lack of time, even though they are enthusiastic in doing that, lack of time and the lack of resources prevent them engaging in the research. So ladies and gentlemen, so this is few things that resonates in my mind about how we can overcome the challenges. We have to appreciate the huge workload on individual physicians. As you are aware, we do not have, like in the Western countries, a primary care doctors in the community. So these hospitals serve as the primary care point. So we need more expertise in these centers, although our the PG trainees who work as acting physicians do a huge workload. But whether we should have board certified physicians who will have a longer stay, and you need to improve the facilities and district and base hospitals to serve these people who are a vulnerable population. And to have a satellite dialysis unit, in my impression, rather than having a huge center in Polonnaruwa, perhaps to have satellite dialysis units would be immensely helpful to these patients to save the time of traveling. And more shared care making with the nephrologist, and the recognition of these physician service would be very, very important. And perhaps the future, I was just reading the most recent journal of the Royal College of Physicians. They have described very well the virtual clinic. Very practical approach, I thought, because these patients have very long-standing, slowly progressive disease. Perhaps to communicate between Padaviya Teaching Hospital, which is the primary care site, and to the Teaching Hospital Anuradhapura, and to get the nephrologist-led decisions. I think this should be perhaps one aspect in the future to overcome the challenges. Thank you very much.
Thank you, Professor Vangasuriya. From unknown CKDU, now we will move on to the next emerging challenge, that is on emerging infections. May I now invite Professor Ranjan Premaratna to deliver his talk on emerging infections.
Good morning to you. First of all, let me thank the Council and the President for giving me an opportunity to address these IMA sessions. My topic on emerging infectious diseases in Sri Lanka. Well, if you look at the evolution of infectious diseases, I would rather concentrate on the timeline of death. If you may appreciate that before 1900, it's mostly bacterial. And after 1900, it's mostly viral. It's starting from, well, flu and so on, then coming to swine flu and the SARS and so on. However, the history of a smallpox extends into the prehistory. The disease likely emerged in human populations about 10,000 BC. But the virus was identified only in 1906. It was after the invention of this Chamberlain filter in 1884. And since then, you can see the viruses have emerged, and it's 1906, you got the smallpox. Then, thereafter, there had been significant discoveries over the past 125 years, organisms, vectors, and hosts. So it's the evolution of technology that is linked to global burden of infectious diseases. Today, infectious diseases account to 25 to 35% of the 60 million deaths that occur worldwide each year. However, 50% reduction in mortality had been observed due to infectious diseases from this period to 2000, and it's mostly you may appreciate that it is the diarrheal illnesses which have come down, including TB and probably the respiratory infections as well. However, world faces challenges from both new and re-emerging infectious diseases. If you look at this, you have got newly emerging, re-emerging, and deliberately emerging infections, including viruses, bacteria, and most importantly, drug-resistant organisms. Emerging and re-emerging infectious diseases. Today's challenge, the critical questions to answer, therefore, are there emerging or re-emerging infectious diseases? How to detect them? Understand how they are emerging or re-emerging and what their impact is. Emerging infectious diseases are defined as whose incidence has increased over the past 30 years. Some diseases have never been seen before, but some were previously documented but without a known etiology. And more than 30 new diseases have been identified in the past 30 years. What are the re-emergings? Some diseases are re-emerging in various parts of the world after being dormant for nearly more than 100 years. Many of these diseases were thought to be controlled through antibiotics. In some, re-emerging diseases are resistant to antibiotics. What are the reasons behind these discoveries then? What is the role of the internists? Well, if you look at the infectious disease epidemiology versus the internists, you have got this very simple circle. You have got the disease epidemiology, you have got the guidelines for disease diagnosis and management, you do a clinical judgment, and you celebrate. Is it that our role? Well, what I feel is, you have got currently known illnesses, but we should think, is the illness that you are dealing with, or the patient is one of them. There you make the clinical judgment, and here is the sort of discovery of a new disease. That is how you should do. So it's basically what I feel is, it's clinician's curiosity and evolution and technology that has led to these phenomenal discoveries. So if you look at the internists, the approach to febrile illness, the key elements therefore will be the history, examination, and investigations with evolution of the technology. So the critical question, how much time can I spend on history taking and examination? Do I have enough time? We are busy, understaffed, work burden, and some think we are genius. Will this approach will work for infectious diseases? Probably it might work for non-communicable diseases. If you look at the threat of emerging infectious diseases in Asia, you have got this Nipah virus, severe acute respiratory distress syndrome, SARS, influenzas, and so on. Then you have got the re-emerging infections, bacterial ones, the viruses and bacteria, there are leptospirus, rickettsial infections, and so on. But on the other side, the drug-resistant organisms, mainly the TB and the extended drug-resistant TB and malaria, and so on. But if you look at the world map, we have no dots, but if you put a dot, probably the country is going to get concealed underneath. But the issue is it because do we have data? Do we do enough? Are we safe? Or are we prepared to do this? The list of emerging and re-emerging infections which are known in here, the West Nile, influenza viruses, melioidosis, rickettsial infections, drug-resistant or multi-drug-resistant organisms, Elizabeth-Kinger infection, dual infections, then the parasitic leishmaniasis, dilofilariasis, toxocariasis, cryptosporidiasis, and cutaneous lava migrans. However, Sri Lanka succeeds. Malaria, if you look at. The scientific discovery of malaria came rather late, that is 1802, had been a threat for ancient civilizations. Near eradication status was reached in 1963, where only 17 cases were detected. However, that re-emerged in massive numbers due to relaxing of control efforts and due to reintroduction. We have achieved. In 2016, September, we declared that we are free. Looking at lymphatic filariasis can be traced back to 4th century BC, and 1967, Brugge Malay infection was completely disappeared from our country. And we declared Sri Lanka eliminate lymphatic filariasis 3rd June 2016. So we are very happy now to go on. Okay, this is a case. This is an 18-year-old boy from Bragama admitted around 6 p.m. with fever for 2 days and body aches, and he was confused and irritable. He had mild neck rigidity and a just palpable spleen, but there was nothing else significant. We entertained a viral etiology bacterial, but malaria was not that much thought because we were in the elimination phase and there were no reported cases in his hometown. 2 hours after admission, pending CT, he developed intermittent opisthoronous posturing, and he was commenced, in fact, on triple treatment. Blood picture was sent to night lab, no abnormal cells, but Plasmodium vivax and malaria ring forms were noted. Is it compatible with our setup? Vivax and malaria. So what do you do next? Thought we are going to repeat the blood film with the experts and to do the malaria antigen as well. And there we reported that it was Plasmodium falciparum, Plasmodium malariae ring forms were positive. So it's still not compatible with our setup because we don't have malaria. So go back to the patient. He had been working in Gambia doing a course in gold industry, returned 1 month back and was on mifloquine prophylaxis, stopped after arrival, and this travel history had not been obtained. The points to learn, travel history is important. Skills of microscopists may deteriorate with low endemicity, and this is important if you are dealing with re-emerging infections. Because malaria, remember we have not eradicated, this monster is still there, so at any point this can resurge again. So we reported this as our experience. Then as I said, this filaria history is gone. This is a 56-year-old female, a worm removed from my eye. More interestingly, 34-year-old female banker, there's a worm going across my eye. Eye surgeon tried to remove it, worm got escaped. I feel it moving across my face, moving lumps, then on the arms. I scratched my tummy over a small lump, and this long worm, I pulled it out. This happened over a time of about 1 week. This is a young lady doctor very recently we encountered from Colombo. She presented with trismus, deviation of mouth to right side, and mild swelling over the temporomandibular joint on the left side, and accounted for a bad tooth, and he got the left mole extracted, followed by antibiotics. There's a localized 3-centimeter nodule accompanied by systemic symptoms, giddiness, nausea, vomiting, and severe headache, suspected of meningoencephalitis, and he was admitted and got multiple antibiotics. In contrast, enhanced MRI scan was done. There's a tubular tortuous structure with a large, in a large area of soft tissue edema. She was then treated with DEC and albendazole and doxycycline. She had partial remission with multiple steroids, including potent like methylprednisolone, ending up with cushingoid features. This is all what happened. So a small lump removed by the plastic surgeons, nearly 3 months, and PCR dialophylar pens. She had morbidity, psychological distress, multiple treatments, direct and indirect losses. I think I got about 100 calls from her every day like on this. So this is dialophyllariasis, a worm which is found in the dog. Brugia malai, considered eliminated from Sri Lanka in 1971. However, we did a night blood survey, and we have found 1.6 children in Gampa district. There was some evidence of exposure to Brugia malai infection. So is it re-emerging now? So the question here to answer is, did Wuchereria branchofti has had cross-immunity against other filarial infections? Does elimination of one parasitic infection predisposes to other parasitic infections? Looking into measles is important as far as annual cause of deaths. In 2013, we had elimination targets set for 2018, but we thought we cannot achieve it. 2015, then we revised to achieve it in 2020. Recent several outbreaks were noticed among adults, and this could well be due to change in immunization schedules, which happened about good 6 years back. And we reported them. Sporadic case of adult measles, which shifted the age groups, the importance of them, that we should know the virus genotypes because there can be introduction to our country as well. So clinical vigilance is needed. Looking at the encephalitic syndromes, in a patient with acute febrile illness, how commonly do you see the following symptoms? Fever, headache, myalgia, and so on. then complications of myocarditis, pancreatitis, hepatitis. They can be due to acute febrile illness of any etiology of tropics. If you look at West Nile, the same symptoms. Then the issue is, as clinicians, whom to suspect West Nile. And this had been reported as emerging in Sri Lanka. This is the transmission cycle. So the etiology of encephalitic syndromes, are they changing? A study done in a pediatric population in our setup, type 2 dengue in 1, and human echovirus, human Boca virus in 5, and human adenovirus. Then another in LRH and National Hospital, dengue virus, mainly that's 40.7% Japanese encephalitis at a lesser extent, and so on. So in CMJ, I noticed this article, friendly fire neurons, antibody-mediated disease of neural system. Are they really autoimmune? Will there be a monster behind? That is the question we have to keep in mind. The flu, we all know, it is rampant now. Melioidosis in Sri Lanka is an emerging infection. Some of the challenging clinical syndromes that we have encountered, few with cavitated pneumonia mimicking TB, few with multiple abscesses in internal organs such as liver, spleen, few with thigh abscesses, with chronic osteomyelitis in hip and femur, and the latest patients just discharged about 2 weeks back, fever, mediastinal lymphedema, and cerebral abscesses due to this infection. The issue is they are rapidly increasing, need long-term in-house treatment with potent, expensive antibiotics for a longer period of time. Can we afford them? We have to keep these patients in our wards. Looking at chikungunya, in 1969, we had the outbreak. We thought we had it had disappeared from us, but however, it reappeared in 2009, probably due to weaning off immunity. So when the next one will be. And there's another case scenario. There's a 24-year-old bus driver who admitted with chikungunya outbreak with multiple severe joint pains with stoop posture. There are several admissions as well as several investigations and treatment, but not responding. He had erythema nodosum or both shins, some hepatosplenomegaly, but these multiple eschars. Recovered with oral treatment, doxycycline. We reported this as well. So rickettsial infections, its history dates back to 1930s, and reduction of incidence probably due to these tetracyclines and chloramphenicol, which are anti-rickettsial antibiotics which are used in the past. However, they re-emerged because these antibiotics are not very commonly used today. But we still don't know the vector densities and their behaviors. Other clinical syndromes encountered, fever and late onset diarrhea, hemophagocytic syndrome, fever and deafness, myocarditis, encephalitis, and pneumonitis, and delayed encephalitic syndrome, which we need to investigate further. However, the true burden of this disease is not really known. Looking at the timeline of antibiotics. So you may appreciate that with the invention of antibiotic, immediately after there is resistance as well. But the issue is there are no discovered antibiotics over the last nearly 2 decades. This is another study we did, ESBL UTI in 52. We found that a larger percentage of them had not been hospitalized or treated previously, suggesting high existence of community-acquired ESBL. And the meropenem resistance was noted in 2 who had received multiple courses of antibiotics as a patient. So reasons of these could be viral infections. 96% they use antibiotics in the community. And we may be having substandard antibiotics, non-adherence to guidelines, and wide use of antibiotics in animal husbandry. So another patient who came with dengue, and the patient came with cefixime and azithromycin combination tablet. Who has imported this? Who has given permission? And for which patients are going to use that? Are the questions that we'll have to answer in future. So this is the TB. And recent survey finds 3% multidrug resistant TB, but no XDR, extended drug resistance. This is another infection which is found in aquatic environments, the Elizabeth Kinga infection, known to cause severe septicemia and septic illness, which one patient came to us, and he ended up with developing non-STEMIA seizures and DIC, but he responded to meropenem. We still don't know what the significance of that, but there are recent reports coming up, there are significance in immunocompetent people as well. So are they re-emerging? There can be dual infections as well, and this is a patient who had both dengue and leptospirosis at the same time, giving a controversial issues in the management. You all know that. Leishmaniasis, visceral leishmaniasis seems to be emerging in Sri Lanka. Okay, are we at a risk of rapid spread? There are 4 historical patterns for emergence and rapid spread. One thing is crowd transition. So people begin to live in much closer proximity, and this is happening in Sri Lanka. War and trade, and the neighboring civilizations come in contact, and they exchange pools of infectious organisms and vectors. Worldwide exploration and colonization is happening again. So what is happening today is global urbanization, increase in population density, poverty, social upheaval, travel, new behaviors like medical and sexual tourism, long-distance trade, technology development, land clearance, weather, climate, and so on. There are several reasons of rapid transmission of highly infectious agents, like genetic changes, the assortment, modern air travel disperses pathogens very rapidly, increased numbers of susceptible targets. This is exactly what happened during the SARS outbreak, and they were in the same lift, going across the world and taking the infection with them and killing at different sites. So this is interspecies transfer. You get mutations with every replication, recombination, and resortment. And for the interspecies transfer, pathogen must overcome 2 major hurdles. One is infect and replicate in human cells, easily transmitted from one human to the other. So if you look at the pig, it can harbor both influenza A and B from human, A from avian, and you can get the new product coming out, which can be highly infectious to man. So both pigs and chicken, the industry we are having in our country. And these all about Hanta, Nipah, and highly pathogenic avian influenza. They have overcome the first hurdle to infect human, but there is no human-to-human transfer. So the infection risks for the future: change in the environment, recreational activities, change in food habits, concept of global village, interspecies transfer, and global warming. So this is happening again. We are destroying the forest, making us at risk for contact with new pathogens and vectors. These for food, we keep them together. We have got, in addition to influenza species, we have got Salmonella mad cow and E. coli species putting us at risk. SARS, with economic growth, desire for game meat, and live animal trading. This is the Hendra-Nipah distribution. Goes with population growth, urbanization, and climate change. You come in contact with them because of ecotourism and so on. These are respiratory, with a short incubation period, respiratory illness with severe flu-like syndromes and can progress to encephalitis. Nipah virus, again similar sort of an infection. Melaka virus, again with urbanization and tourism. Ebola virus with bushmeat. So we are going for recreative activities and other experiments. Monkey farming, intensive pig farming associated with Ebola resistant. What about hemorrhagic fevers? Are we at risk? Cholera, of course, seems to spread across the globe. And are we changing our food habits? Tonight, are you going to eat a little bit of raw stuff here? Think about it. And plague, of course, there are re-emerging plague coming up. So are we safe with this? Looking at Zika, we had not documented, is Sri Lanka safe? But there are a lot of countries around us getting this, and we have the mosquito as well. Through the customs, can we get more? So are we going to talk about a safe Sri Lanka? What things as internists, the responsibility we have? Because we are experiencing all this in this setup today, right? I think you can understand what they are, so it's happening. So emerging and re-emerging infections in Sri Lanka, right? It is basically what I feel is it's clinicians' curiosity. So it is your responsibility. Thank you.
Thank you, Professor Premaratna. From the challenge that is just over emerging infection, we are now moving to a next challenge that the Sri Lankan aging population is bound to face, dementia. I will call upon Professor Ravin Hangwal to update us on this challenge.
Yes, thank you very much. I wonder whether you recognize any of these people. What do you think they had in common? Well, when I put this slide to the medical student, they don't know any of them. And my department has kindly suggested to me that perhaps it's a reflection of the increasing age gap between me and the students, and I should update the pictures, but, well, I hope you do recognize at least one of them. Ronald Reagan, Margaret Thatcher is there, Peter Falk from my favorite detective series, Columbo, Nusrat Bhutto, wife of Ali Bhutto, Charlton Heston, another actor, and our own Gamini Korea, who was Secretary General of UNCTAD, brilliant man. They all had one thing in common, they all died of Alzheimer's dementia, which I'm going to talk about now. So it is no respect of intellect or persons. I'm going to talk on dementia, but when I say dementia, it would be mainly on Alzheimer's, but dementia is not only Alzheimer's. Alzheimer's is the main cause, of course. Going back in history, Alois Alzheimer, more than 100 years ago, admitted this lady called Auguste Diener to the Frankfurt mental hospital. She had severe memory loss and deteriorated very, very quickly within 4 years and died. And then Alzheimer, who was also a psychiatrist, neurologist, and a neuropathologist, all rolled into one. We don't get that combination nowadays since the PGM does not allow that kind of activity. I don't know why, but anyway, those are the days when you could do what you liked. So he very diligently followed this lady up. In fact, refused to transfer her from the hospital until she died, and then examined her brain and found for the first time, demonstrated these two unique features of Alzheimer's, what we call the plaques and the neurofibrillary tangles. The plaques are the beta amyloid proteins, which are found outside the cells. And the neurofibrillary tangles are intracellular. Those are the what we call the tau proteins, which are found inside. The exact significance is yet not worked out, but we presume that these collections are toxic to the brain and damage the nerve cells. But the exact mechanisms are still not quite clear even after 100 years. But these are the hallmarks of dementia. Well, why are we talking about dementia today? This audience is not in that category, or you think so? Well, it's a emerging problem, and in 2050 we would have, they say, 135 million people with dementia. It's a reflection of aging, and you will find here that the main impact would be on the low and middle income countries, since our population is aging relatively. And it would hit Sri Lanka rather hard because though we are not very rich, our lifespan is quite high compared to other neighboring countries, and it's about, I think, 75 now and increasing. And so we are going to end up with a lot of people with the problem, since statistically, if you are over 65, you have a 5 to 7% chance, and that's for the retiring professors to think about. And if you are in your 80s, it's about 20%. So statistically, without doing anything. So therefore, who knows, you might be in that unlucky percentage. Now, as I said, Alzheimer's is not the only cause. We have other causes, many other causes, but for the clinician, you have to worry only about 3 or 4. That's it. You will never see the other causes in your lifetime. Alzheimer's accounts for 70% of the dementias, and vascular, well, about 17%, and the other dementias, another 13%. So statistically, even if you don't do any other investigations, you can guess and say it's Alzheimer's, and you would be right most of the time. However, that's not how we practice medicine. We do some investigations to pin it down. But okay, let's see how is that important. So in addition to Alzheimer's, with Alzheimer's, we identified 4 clinical syndromes, if you are a clinician, which would be 90% of the cases you would see. So of course, on top we have Alzheimer's, the classic dementia presenting with severe memory loss, short-term memory loss. And then of course the vascular dementias, which are becoming important because people with high cardiovascular risk have micro blockages in the brain. And that leads to a type of Alzheimer's called vascular dementia. Of course, there's overlap, so people can have both. And that would present with a lot of cardiovascular symptoms, such as TIAs, and we have a kind of a classic stepwise progression where with each insult, there's a sharp deterioration of the cognitive functions. The third type you may not have heard about, but it's a fairly common one. It's called Lewy body dementia. And that's associated with Parkinson's-like symptoms. And they're very sensitive to antipsychotics. And that's the importance of that. It is not Parkinson's dementia. There's another dementia which comes with the Parkinson's disease, that dementia of Parkinson's disease. Don't confuse that with Lewy body dementia. Here the Parkinson's symptoms come afterwards, and the dementia symptoms come first. In Parkinson's dementia, the Parkinson's symptoms come first, and then the dementia symptoms. And the management and the prognosis is slightly different. And last of all, you get a condition called frontotemporal dementia, which presents with behavioral problems. And that can be very, very distressing for the family because very calm and kind of sensible people start behaving rather in an erratic manner. Of course, you might say that not necessarily a sign of frontotemporal dementia. We see that happening all the time, especially in a political field. But however, this is a medical problem, and very soon, of course, they will manifest the neurological symptoms. When I say soon, maybe up to 3 years. So I've had patients who have been very, very contained gentlemen who suddenly started looking at the neighbor's wife kind of thing and started giving gifts. In fact, one of my patients recently was referred by one of my medical colleagues when the very nice gentleman next door started giving rather expensive gifts to his wife. And he was dead right. He did have frontotemporal dementia, so I'm treating him now. So anyway, this is how this goes. Right. So number 1 is Alzheimer's, of course. What are the risk factors for dementia? The risk factor, the main factor, of course, is age, and there's nothing we can do about that. We all age. Then, of course, the vascular factors, which we can do something about, and that's where the physicians will come in. And important head trauma, which we don't think about now. Of course, you might say, well, hang on, we don't have that many accidents. Well, we do. There are 12,000 people now with neurological deficits after road traffic accidents in Sri Lanka, right at the moment. That's what Dr. Sunipera tells me. And even if you don't have an obvious accident, even a close brain, what called traumatic brain injury due to contact sports can put you at risk of dementia. And that's something we have to pay attention to now, especially with children going into contact sports. Not necessarily boxing. Even hockey is considered a contact sports. Okay, and that puts you at high risk of dementia. So, in fact, a neurologist was asked whether he would put his children into these sports. Said no, definitely not. He would not allow any of them to play either rugby, definitely not boxing, hockey, or any of the what we call the contact sports. Well, I'm not suggesting that pull out your relatives from these sports, but anyway, something to think about. Especially if they have concussion, you have to be very careful. You don't send them back into the field immediately. It used to be a badge of honor in rugby that you have to get concussed, otherwise you are not a, well, good player. That is no longer something to laugh about. Right, anyway. So family history is important. There's a very small percentage who get dementia due to genetic defects. And of course, depression puts you at risk. We don't know why, but it does. So as you grow older, 3 things happen. The first is your memory goes, and then you can't remember the other 2. Happens to me all the time. I start putting a list of reasons, and then, okay, number 1 is this, number, 2, 3, go and read up. I have forgotten. Unless it's, of course, on the slide, which acts as a prompt. Right, so these are the important genes. The first 2 are important in early dementia, and that is not a common thing. But however, number 3 is apolipoprotein E4. And if you have that gene, you are about 30% more likely to get dementia. So there's some value in identifying whether you have it or not. In fact, 25 to 30% of the population have the ApoE4. If you have the ApoE2, you are protected. If you have ApoE3, which is the common one, it's neutral. Okay. So ApoE4 can be identified, and then we can test ourselves and see whether we are at 30% higher risk. Can we do anything about it? Well, yes and no. So let me answer that question later. Right. So when you look at dementia, how does it work out? You have the preclinical dementia. Dementia, Alzheimer's, the early signs develop 20 years or 30 years before. So in fact, all of us here who are going to get Alzheimer's, and I'm afraid some are going to get, already have the changes, okay? And if we can do a PET amyloid scan, we can identify it. So $5,000, but anyway, it can be done. And then, of course, if you are going into dementia, you have an early sign called MCI, minimal cognitive impairment. And then, of course, later you go into dementia. So that's how this progresses. In MCI, there is memory loss, but there are no functional impairments. You function okay, but you feel that, you are not remembering things as you used to, which, of course, can be worrying, and in fact happens to us, all of us. So, and I'm also thinking that I'm not as sharp as in the days of old when I could remember all these names, especially when I'm teaching the postgraduates. I get a bit pushed. But of course, the Google comes to my salvation. I don't look it up. I tell them, you look it up and tell me, and pretend that I know the answer. Right. How do you diagnose? Well, we have a easy one is we use a rating scale. So in minimal cognitive impairment, you will have a MMSE is normal, functionally normal. It's only the clinical report. So don't ignore clinical reports. Take them seriously. I will not go into the differentiation of amnestic, non-amnestic types since they are a bit short of time. So let's go on to the diagnosis. It goes in 3-4 steps. First, to suspect, and suspicion is always the report of the patient. When they say, I am having problems, or the relatives say, do not ignore it. Do please screen, and at least do the screening test, which you can do very easily. And if you are pushed for time and you don't have the time as a clinician, you can always refer. For example, we have a screening unit in our department in Colombo. So if you make a telephone call, you can book an appointment, and the patient can get it done there. Costs 1,000 rupees, that's it. And they will come back with the report to you. So you can then just tell them, get the appointment, get it done, come back with the report. And that saves you 1 hour of time. And I know clinicians have no time to be doing these rating scales. We will do it for you, and that's not a expensive test to do. They are very specific, actually. And what we look for are these deficits in 6 domains of cognitive functions: complex attention, executive ability, learning and memory, language, perception, perceptual, and social cognition. So these 6 areas are what we look at in the rating scales. And if you find deficits at least in 1, that's almost diagnostic according to the DSM-5. And these are the higher functions, which the neurologists do not test for usually, and needs different tests. So your normal routine test will come normal, especially if the person is a fairly high functioning person, like a teacher. Even with dementia, they will score full marks. Right. So what are the tools we use? These are the 3 tools we use in our department: the MMSC, the Montreal Cognitive Assessment, and the Neurocognitive Assessment. Very sensitive, the last one, almost guaranteed to pick it up if you have even mild impairment. some of your colleagues have braved it, but it's a bit threatening because you try to do it and you get a bit anxious, and that can affect your assessment. I haven't undergone this test. In fact, the one in the middle was what Donald Trump underwent, and he scored full marks on it. And therefore said he does not have any problems, but other people said, well, that doesn't mean that you don't. But, right, anyway, investigations, these are the biomarkers we can use, but we can't use it in Sri Lanka. If you analyze the CSF, you can identify these deficits, not diagnostic, but can indicate a problem. So these are the products that you find in the brain. So they get less in the CSF and more in the brain. So that's how it goes like. So low CSF amyloid beta 42, high CSF tau, it's reversed, and a reduced hippocampal volume, and a medial temporal atrophy. So these are the changes. Neuroimaging is helpful, but it can't exactly diagnose, but we mainly use it to differentiate Alzheimer's from vascular dementia. So the vascular dementia picture is different to Alzheimer's. So that's helpful in determining where you should put your management emphasis. So that's the only reason we do that. Of course, the PET amyloid scan will be useful if you can do it. It's expensive, and that will show the distribution of amyloid, which starts many, many, many years earlier. However, even if you have it, doesn't mean you will get dementia. It's only 50% to progress. But if it's negative, then you can be more or less sure that you will not get dementia. So it's of negative predictive value, right? But maybe that might also comfort you, but again, it's not available. Okay, treatment. What can we do? We can treat symptomatically the memory disturbances. You can treat the behaviors arising out of the damage. We cannot modify the disease at the moment. So the last thing is not possible. And these are the medicines that are available in the world today. There are, basically 4 really. Donepezil, rivastigmine, galantamine, memantine. The first 3 are anticholinesterase inhibitors. Galantamine is not available in Sri Lanka, but we have donepezil and rivastigmine in the private sector. Unfortunately, not yet in the government hospital, but we will get it next year. Memantine is an NMDA antagonist, which is the latest one, and that's all we have. And the FDA, of course, in their guidance would say you start with a cholinesterase inhibitor first, and then add on the memantine later, when the dementia becomes more severe. However, in Sri Lanka, I tend to do it the other way. I start with the memantine and add the donepezil if necessary later, because memantine is actually better and also has very much less side effects, hardly ever, and the dosing is very simple. You start with 5 milligrams and go to 20, increasing by 5 milligrams every 2 weeks, and 20 is the optimum, that's it. So go from 5 to 20, keep it at 20 till patient lives, that's it. That's the only principle you have to follow. Side effects are very rare. And don't stop halfway. Don't give half dose of memantine. Problem with the cost, of course, but they're not very expensive because we get our medicines from India. They are not the innovator, they are the clones. And for example, in the States, it will cost you $20,000 a month. Here, a tablet is about 50 rupees. So 50 rupees into, you can calculate the cost per month is about 2,000, 3,000 rupees for memantine. So we don't have to follow the FDA guidelines. We can give the expensive one, which is not expensive in Sri Lanka. So paradoxically, we can give the best treatment compared to the States. Right. And of course, manage the expectations of the patients. There are, of course, always behavioral problems which come about, unfortunately, and these are very difficult to manage because they get very restless, agitated, and not much we can do other than having a good care. And if really pushed, we will give small doses of antipsychotics, not heavy ones because they are very sensitive. And the one popular one that we use is quetiapine, which is relatively gentle and works fine. Then, of course, the last question which I said, can you do anything about it if, let's say, you find you have the apoprotein gene or you think your relatives have had dementia and you are wondering, can I do anything? Well, yes and no. Well, basically, I'll cut it short and say there are 3 things you can do to reduce your risk. 3 things that are proven by science. Okay. So, number one, Alzheimer's Association, of course, has 10 things you can do, but they are not proven. So the 3 proven things, number one is exercise. You exercise, aerobic exercise, more than 3 hours a week. And now they have worked out that if you exercise 55 hours in 6 months, that puts your risk down by about 30–40%. So that's not a small thing. Right, so 3 hours means half an hour, 5 days a week. How many of us are doing that right now? And that will reduce the risk of so many other diseases for you in one go. Sleep well, very important to sleep 8 hours minimum. We don't do that. And eat well. That means don't eat too many carbohydrates, cut down the fats, and eat sensibly. If you do those 3 things only starting today, you will cut your risk of Alzheimer's by 30%. 30%. Though untreatable, it's preventable in that sense. So that's the paradox of Alzheimer's. Right, where is it? Right. In fact, they tried this program in 10 selected people, this fairly famous paper. 10 selected people, they put in everything we know about how to prevent Alzheimer's, including the not so proven ones, including turmeric, olive oil, fasting for 12 hours, all the vitamins possible. And in 10 people, 9 people reversed their dementia. But the study has not been replicated. And Dr. Dale Bredesen, of course being an American, has now, well, he is selling the program. You can buy it on the internet. Right, don't you? Okay, I'll skip that. The finger study is the most famous one about diet and Alzheimer's, okay? So that's the one where they show that if you kind of take care of your diet, exercise, you can save your brain. Well, there's documented proof about that. Right, so that's about what I want to say today, since the time is short, but it's a very interesting and important topic and relevant for you also, because I know some doctors are having big problems with their aging parents, especially when they go abroad and don't come back. Well, and we had to look after them. And right, okay. So just to finish, Alois Alzheimer died at 51, soon after being appointed professor of psychiatry, which is, well, respect, I suppose. Well, what happened, he was on the train to Berlin to take up the appointment. He got an infection, sore throat, and he got a rheumatic heart failure and died, and there were no antibiotics those days to treat. So he died at the same age as his patient who died of dementia. Well, we can treat Alzheimer's problem, but we can't treat the patient's problem yet. So thank you very much. Thank you for listening.
Thank you, Professor Hangwala. Since we have about 5 minutes of question time, I am sure our research persons will be happy to answer some questions raised. You can answer this.
I'm very happy to see of my train as a this is actually just a thought about what Professor Premaratna brought into the discussion about the burden of continuing antibiotics, especially in melioidosis and other chronic infections, especially in the maintenance phase. I think it's time that we think about, programs like, I have just returned from my foreign training in UK, things like outpatient antibiotic therapy, where, you get the patient to come daily and we administer a high dose of, antibiotics. Might be a daunting task, getting, the newer antibiotics into the scene, but I suppose cost effectiveness might be better. Any thoughts about that, sir?
Yeah, well, it's a very good question, because we have really thought of doing this sort of thing not only for these tropical illnesses, but even for infective endocarditis, whether we can sort of get the patients come to the wards to get the regular injections in the wards. But the thing is, our administration does not allow that. That is the problem, because they don't allow any antibiotics which are on high end to keep in the wards for a discharge ticket. So we'll have to negotiate with the ministry probably, whether we could, because I mean, I don't want, I think you know what's going on, so I don't want to elaborate on that in here. That is the problem that we are facing. Otherwise, I mean, if we have oral ones, then yes, we can go ahead with that. But the efficacy, where once you control an infection like melioidosis with hypotension going for about 2 weeks, and then send the patient for continuation outside, apart from known oral treatment, then it is allowed. But if she needs IV, then I don't know. We have had several patients. I think you yourself must have experienced that patient with septic arthritis who went in and out by himself as well. He went to the local hospital to get the injections, but again he came bad. So that is how it is a burden. Yeah.
I think Ranjan brought up a good point, because now local hospitals, we have so many patients in tertiary care centers just admitted to get antibiotics, melioidosis, ESBL, pneumonias, and even for heparin. But local hospitals, primary care centers are just without patients, I mean inward patients. And if you can make a mechanism where this, along with the medications, these patients can be transferred to the local place, because still in the state sector. And then this issue will not arise. It is somebody need to get an initiative that if somebody needs an antibiotic for longer than this time, and why not continue this antibiotic purchase from the tertiary care center, transferred to a local hospital, and if something happens, we are happy to take them back. So that sort of arrangement can always be done. I mean, I don't think that our authorities, I don't know how they will address this, but that is something that we sometimes try. We almost force the patients. You go there, we are sure that antibiotic is there, you go and get a penicillin and whatever they are there. Then this high-end antibiotics may not be possible, because they are only in the tertiary care center to get a penicillin. That's a real waste.
The other thing is the acceptability of the communities is a problem, because even how much that we try to sort of convince them, okay, you are going to get the same drug in the other hospital, they stay there for about a couple of days and come back. That is the other problem. They have no much of probably within inverted commas faith.
It has happened over many years. I think our doctor community is also responsible to some extent to that. They also don't want that this sort of so-called ill patient to be under their care. They like them to be under tertiary or big centers. Since there are no questions and we are close to lunchtime, can I ask Professor Senaka Rajapaksa to distribute the tokens of appreciation and the certificates to our resource personnel? Professor Kamani Manigasuri. And Professor Ravin Hangal. Thank you, and we'll break up for lunch.
And I have a small token for